I'll tell you a little bit about me as we go along. As was said, I'm the health program specialist at an organization called Realize. Realize is one of the national partner organizations, just like CADI or the Canadian HIV/AIDS Legal Network, or ACAS. QUIGR, which was our old name, the Canadian Working Group on HIV and Rehabilitation, has now changed our name to Realize because it's much easier than QUIGR, which no one could spell or say, and it didn't make any sense as an acronym. So we've changed that up, and I'm here today to talk about HIV and aging. And so I want this to be as useful as possible to all of you and to address what questions and concerns and interests you have. So I'm going to do a little brief introduction overview to the topic, and then I'm going to ask for you to be involved a little bit in setting the agenda for the rest of the night by participating with our meal over here. So, as I mentioned, we are a national organization at Realize. We do research, education, policy, and practice related to HIV and disability. And so we look at the lives of people living with HIV and other episodic disabilities, which is what we refer to a health condition that has periods of illness and wellness. Sometimes good days, sometimes bad days, sometimes good years, sometimes bad years. And we put HIV into that category of episodic disability, and we'll talk a little bit about that as we go forward. But we take a rehabilitation lens to everything we do. So when we talk about rehabilitation, we're talking about formal rehabilitation health services like physiotherapy and occupational therapy and speech-language pathology, but we're also talking about anything and everything that's a service or program or support that helps people to live the best possible quality of life with HIV or another episodic disability. So that could be anything from a program like this that you're having tonight, to a food lunch program, to a counseling session with a one-on-one mental health counselor. Could be anything that's helping people to overcome any barriers that they experience to living a good life like they want to live. And so my focus at Realize is on HIV and aging. And so I'm looking at people who are growing older with HIV across the life course, but also people who are over 50 and who are either living with HIV already or who are vulnerable to getting HIV at an older age. So I want to talk tonight a little bit about assumptions that people make about aging. And this will tie into some of the stuff that I'll speak to a little bit later on. But I'm also going to talk about diversity and what we mean when we talk about aging, and what do we know and not know about aging with HIV. I can tell you that there's still quite a bit that we don't know, unfortunately. But what are we doing about it, and how are we going to get there to the answers that we want? So I want to know from you first, if we can just have a brief discussion, nothing formal, about how is aging viewed in your culture. And when I'm talking about culture, I'm not only talking about ethnicity, I'm talking about if you're LGBT, how is aging viewed within that culture? How is aging viewed for women versus men? Talk to me about how aging, what kinds of misconceptions or stereotypes or positive things there are, assumptions about aging. You can just show them. Okay, so misconceptions about sexuality and aging. Yes, there's a lot of assumptions that older people beyond a certain age, someone said 45, could be any number, but some people think that you no longer have sex or you no longer have sexual feelings when you're over that certain age. I'm going to tell you later that that's not true, and I'm sure some of you already know this, but yes, definitely a stereotype or a misconception. What else? Loss of energy? Yeah, so maybe the idea that older people are more sedentary, more less going out, doing activities, things like that. Yeah. What else? Yeah, so what's the misconception or the stereotype that all older people have dementia? So a lot of times older adults are assumed to for their minds to function less sharply, or they're assumed to forget things, or other symptoms of dementia. That's right. Is that true? People turning to religion as they get older. Yeah. So you think that's a myth or a misconception, or you think that's true? So you think something about having a health condition might steer you more towards that spiritual path. Okay. So you're saying this is how the people in your life around you start to refer to you with these terms of being an elder. Any other thoughts? Are there any positive views about aging? About experience, yeah. What else? Anything? Okay, you think that as we age, we become more understanding of others? Yeah, so it's possible that maybe through experiencing more of life's challenges, you come to have a little more compassion for people who are facing difficult situations. So, okay, so you're worried about the impact that you have on younger generations?
Yes.
Okay, yeah, so all of these things that we've talked about are things that are commonly held beliefs about older people. Doesn't mean that they're true or not. I think sometimes they are for some people, sometimes they're not, and this is why they're stereotypes, right? We can't assume that for all older adults they become more wise as a result of their experience. We can't assume that all older adults are or are not interested in having sex. We can't assume that people become more stubborn or more open or less compassionate or more. This is just like any stereotype. We have these views about older people and about aging that get perpetuated through all of the things we see in the media, through the way that we talk to each other when younger people talk to older people, etc. And so what I want us to keep in mind throughout tonight, and as you take the information forward, is that what is important to people as they age is a lot of times the same things that were important to them over the course of their life. Their values have not changed. Maybe the way that they operationalize some of those things, maybe the path they take in terms of activities, etc. They encounter barriers or challenges, but they have the same wishes and the same heart as they have always had. And so this is really important when we talk about how sometimes older people's values and wishes get discounted as they get older. And we sometimes see this in the world of HIV and aging too. And I want to put out there that as you age with HIV, your values and wishes and all of these aspects of your health are equally as important as they are even when you're younger. So a little bit about what we're talking about when we talk about HIV and aging. There's lots of ways to sort of think about this topic, and I want to just address a few of them. Are we talking about people who are living a long time with HIV, or are we talking about people who are older with HIV? Because those are sometimes two different things, right? Sometimes people are 30 years old, but they've been living with HIV for a very long time, sometimes since they were born. The question I always get is, well, if we're talking about aging with HIV, aren't we all aging? And that's true. From the minute that each of us show up here, we're aging. And so I try to be careful about my language when I'm sharing the results of certain research studies and when we're having a dialogue about whether I'm talking specifically about older people living with HIV or whether I'm talking about the process of aging with HIV, which can start from a very young age. Sometimes I'm actually talking about the combination of being a long-term survivor and being older. So I'll try to be explicit about that, but if I'm not clear on something and you have a question, please let me know. This is the same thing when we talk about aging versus aged. So sometimes this is just the terminology that gets used. A person who is older already would be considered aged. A person who is younger and moving towards older age we might call aging. We also have to consider what's called cohort effects. Does anyone know what that means? So basically it means that you have people who were diagnosed with HIV before there was medication to treat HIV. And they've been living with HIV for many, many years, right, since before 1996. We have people who are the same age as those people, but who've been living with HIV for a longer, or for a shorter amount of time. So they've always had access to HIV treatment. Their experience is going to look very different, because for the people who had HIV before there was any medication, they lived through a period where their immune systems were very potentially damaged by HIV without having access to therapy and not knowing when there would be treatment for HIV. And so that affects their social lives in terms of experience of losing other people around them who might have died from HIV before there was treatment. And that's not to say that people who have been living with HIV for a shorter amount of time haven't also experienced loss. But I'm saying that the personal, internal experience of living with HIV changes depending on when in the cycle of history you were diagnosed. So you also may have someone who is newly diagnosed at age 30. They're in the midst of establishing themselves in their career. They may or may not have a long-term partner. And then you may have someone who's newly diagnosed at age 55 who has had a long time in their life to establish their career. They may have had savings in terms of their financial resources up to that age. They may have been able to work all that time leading up to age 55, and then they're diagnosed and they're close to their retirement. They may have a stable partnership that they're in terms of their support systems. And so it matters not only when in history a person was diagnosed, but it also matters when in their life course a person was diagnosed. So all of this to say that when we talk about HIV and aging, we're talking about many, many different groups of people, right? We're talking about people who are newly diagnosed and older. We're talking about people who have lived with HIV long term and are older. We're talking about people who've lived with HIV long time but they're younger. So all of this comes into play. And again, if I'm not specific when I talk about some of the research and the results, please put up your hand and flag me so that I can make sure that we're clear about who exactly we're talking about when we get to these. One other thing is that we're very limited in terms of the data that we sometimes have on HIV and aging, and the reason for that is because the powers that be that collect the information on statistical information on HIV infections in Canada have historically and still do lump everyone over 50 into one category. So we have age categories for, under age 20, 20 to 29, 30 to 39, 40 to 49, and then we have everyone over 50. Well, in my view, the experiences and the needs and the preferences of people who are 55 may look different from people who are 85, and sometimes we actually have no way to distinguish between the people in that big group and how many of them are younger and how many of them are older. Yes, and this is another question that comes up around HIV and aging. Why do we say 50 and older is aging? When in the general population we talk about people who are 65 and older, for example. The reason being for this very thing. We don't have data that's specific to people who are 60 and older or 65 and older. All we have is this lumped together data on people who are 50 and older, so that's the best we can do in terms of when we're talking about how many people that is, where they live, maybe even what some of their needs are. So this has been a limiting factor in our ability to explore HIV and aging more clearly. Okay, so how do we know what we know about HIV and aging? We know through lived experience. So any of you who are living with HIV, who are aging yourselves, you know what kind of things are happening in your life if you're experiencing any changes from when you were younger. If you see these amongst your peers or your friends or your siblings or those people around you who are HIV negative, if you see differences between yourselves and those people. We also know from research, so this is a budding area of research. This is something that I consider my sort of bread and butter in terms of where I know this information from. There's lots and lots of research, but not enough, and not enough on specific communities. So we'll talk about that in a moment. And then we know it through information sharing. And one of the ways that we do information sharing is through a group called the National Coordinating Committee on HIV and Aging. This is a group of stakeholders from across Canada, researchers, frontline service providers, older adults living with HIV. We meet on the phone 4 times a year, and we talk about what's going on across the country in HIV and aging. So are there new programs and services? Are there new needs emerging? Are there new challenges and issues? And if that's something that you're interested in being part of in terms of a conversation, you can definitely let me know because we can loop you in. It's an open invitation. Going back to research for a second, there have been some large studies that have sort of set the way for us and how we talk about HIV and aging. The biggest one was this ROA study, the research on older adults with HIV. That was done in the States in 2006, and it was the first major survey of people aging with HIV done anywhere. And so it was over 900 participants from New York City who were over the age of 50. They asked questions about all domains of their life, from social support to health conditions to mental health, all of those things. And they have over 1 million pieces of data from that study, and they still do new analyses. Unfortunately, we haven't been able to, in Canada, do a similar study. We haven't been able to get funding to do a study specifically on the needs and care preferences of older adults living with HIV, and this is something that I am constantly advocating for, that we really need to understand this better. Uncharted territory in the middle there is a similar study that was done in the UK. That's all I'll say about that, but some of the relevant gaps in the research on HIV and aging that I think are really important for us to fill very soon, if we can, are experiences of older Canadians living with HIV who live in rural areas. So most of the research that we do is based in cities, specifically in Montreal, Toronto, and Vancouver. Immigrants, refugees, and non-status people, and what are their experiences aging with HIV, because there are far different levels of access to services, especially when there are language barriers and eligibility barriers. Diverse ethnocultural communities. So in prepping for this presentation, I started to try to look at where there was data that we could tease out that was specific to Asian older adults living with HIV, and I could find almost none that I could tease out specifically. And that's a problem, because we need to understand if there are any needs of different ethnocultural communities that aren't being addressed well by the services that we have. And that's not only true for the Asian community, but for many different other ethnic communities as well. And this is another thing that I'm hoping we can remedy very soon. And then people age 60 and older. So a lot of the research that we have on people aging with HIV is about people who are in that bracket of age 50 to 60. What about people who are now 65 and 70 and 80, and what are their needs as they reach those older ages? So these are all areas that I think we need to continue to work on. So I'm going to ask now, for the rest of the evening, what I'd like to talk about is some of these issues that have to do with HIV and aging. So cognitive health, disability and functioning, housing, sexual health, mental and emotional health, finances, comorbidities or other health conditions, and inclusion and social support. So what I'm going to do is I'm going to ask you to do 3 things. The first is I'm going to come around and give you each 3 stickers, and I want you to, in this inner circle here, and the colors correspond with the words, I'm going to ask you to put your 3 stickers in the areas where you want me to spend the most time on talking about tonight. So I will briefly touch on everything, but we don't have time to go into detail on all of the aspects of HIV and aging in an hour and 15 minutes. So I'm going to ask you to vote for what your chosen topics are. The second thing I'm going to ask you to do is if you have specific questions about any of these topics, write them on these sticky notes and stick them beside the topic. And the third thing is if you have any strategies that you use to overcome barriers and challenges in any of these areas, you can write them on these orange stickies. So I'll come and distribute these. We'll take about 10 minutes or so you can vote and you can share your questions and strategies, and then we'll come back and I'll try to use this to guide us through the rest of the night as we talk about some of these issues, okay? Okay. Okay, so now this one, and then I think we'll try to focus on those 4 areas: housing, financial, comorbidities, and mental health. I'll touch on the other areas, and I'm happy to stick around after if you have specific questions, and of course happy to share the slides as well, so if I don't go into much detail there, that's fine. And we'll go from there. I'm not surprised, although I can tell you that rarely do people choose this one. But it's interesting because once we start to discuss this, a lot of people it resonates more with people. I think there's a bias. People don't want to associate with the word of disability, and we can talk a little bit more about that when we get to it. But a lot of people do experience issues with their day-to-day function. And so sometimes I think this one is a little bit forgotten. Yeah, it could be the result of those concurrent health conditions, but sometimes we think of it a little bit differently, at least we do at Realize, because the disability or the functioning issues are sort of the outcome, whereas this is sometimes the cause or the diagnosis. And sometimes this is actually what people most experience or feel the impact of, in terms of if they're having difficulty with mobility, for example, that has a big impact on their life no matter what is causing it. And so, yes, you're right, oftentimes disability results from having more than one chronic health condition, and so that may have been sort of taken up in that. You'll notice that people aging with HIV is in the middle because none of these things obviously exist in isolation. All of our lives include all of these components. Yeah. So we're not going to spend too much time on cognitive health, but I'm going to provide just a very, very brief overview. You've probably heard before that people talk about HIV-associated neurocognitive disorder. This can be quite common, but in many people it's actually asymptomatic. You don't experience any difficulties in your day-to-day life, but if you were to go for neuropsychological testing, like for example is available at St. Michael's Hospital, they may say that you have asymptomatic neurocognitive impairment. Sometimes people are very scared by this, because the types of neurocognitive impairment that people are used to seeing are serious dementias. And also in the early days of HIV, people experienced what's called HIV-associated dementia. This was a very serious form. The types that people experience now, on the whole, are quite mild as compared to that, but do affect sometimes people's ability to concentrate or pay attention, people's ability to remember certain things, executive functioning, so that's the same kind of thing as multitasking. So can be difficult to focus on doing more than one thing at a time. And one of the things that is important in this is that it can interfere with people remembering to take their HIV medication, which, as you know, can be problematic. So the thing to remember is that these similar symptoms can be caused not only by HIV-associated neurocognitive disorder, but also by conditions like depression. And so it's very important if you're experiencing difficulty with your concentration or your memory that you would go to your healthcare provider and you would discuss those symptoms, not assuming that you necessarily have hand, but assuming that it could be any number of things here. So issues with concentration or paying attention for long periods of time, issues with memory, forgetting words or names or things like that. On a repetitive basis. We all have times when we have, we don't remember something, but this is like something that persists over time. Do you have a question?
No.
So he had lost his memory completely. Yeah. This was at the time that he was diagnosed.
Yeah.
So I have no idea what that person's circumstance would be, but sometimes when people experience what they perceive as a very traumatic event, they could have a serious depression where it really impedes their cognitive function. I don't know that I would say that would necessarily be hand, but that sounds very serious. Was he able to get it worked out? So I'm going to talk about two specific findings about cognitive health, the CIPHER study and the Women's Interagency HIV study. So in the CIPHER study, 156 out of 448 participants had some sort of neurocognitive impairment. And these are all people living with HIV. Also in the women's study, it found that women living with HIV on the whole, not every woman, but on the whole, performed less well on some of the tests that were measuring for cognitive function. But it's really important to understand this next point here, which is that HIV had less of an effect on their cognitive performance than education, age, race, ethnicity, and very specifically, income and reading level. So this is to say that although a lot of people attribute having these kinds of neurocognitive symptoms to being a person living with HIV, there are actually a lot of different circumstances in someone's life that can affect their cognitive performance. And these are all things that don't necessarily sort of get factored in when people go through the testing. So, for example, one of the things that helps protect against neurocognitive impairment is something called cognitive reserve. There it is. Wow, that's a bit weird that I'm talking about memory problems. Cognitive reserve. And so cognitive reserve is actually using your brain in many different ways to formulate different pathways. And so people who have had longer time in education, people who try new things a lot, who socialize, who get out and test their brains, so to speak, they build their cognitive reserve. So if you think about the brain is not a muscle, but if you think of it like a muscle, the more you work it, the bigger it gets and the stronger it gets. The same thing is true of your brain. The more you use it and the more it's stimulated, the more pathways get formed and the better your cognitive reserve is. And so that's why these things like reading level and level of education can actually impact people's cognitive health more so than their HIV status. What's also really important is that it's unclear whether there's actually an age effect when we're talking about HIV-associated neurocognitive disorder. So there's nothing to say that as you age with HIV, you're more likely to get hand than anyone who's younger living with HIV. So this is not specifically an aging with HIV issue, it's a living with HIV issue, and it depends on a lot of other factors as well. So just some strategies, again, things I talked about, building cognitive reserve, so trying new things. One of the things that can help build cognitive reserve is using your non-dominant hand to do activities. So if you always do everything with your right hand, because you're right-handed, you brush your teeth with your right hand, brush your teeth with your left hand. It's a little tricky at first because you're not used to it, but doing those kind of things can actually create those new pathways in your brain. Screening and treating for HIV is one of the biggest factors in terms of decreasing the risk of neurocognitive impairment. So getting onto antiretroviral therapy is very important. That's why the recent evidence that has come out about getting people onto treatment is that the sooner we get them onto treatment, the better. And the reason for that is because then we don't allow any time for HIV to have its effects on the brain and on other systems within the body, and we can control its effect on cognitive function. Also controlling for cardiovascular risk factors. So these are things like controlling diabetes, reducing obesity, not smoking, because what's good for your heart is good for your brain. And anything that is bad for your heart, like the things I just mentioned, can also reduce circulation and blood flow to your brain, which can therefore make it less able to weather these kinds of challenges. And as I said, dealing with depression, which can cause many of the same symptoms, is another really important factor. You may have also heard about these restorative brain training approaches. These are just sort of becoming talked about, I guess, in community, and they're still being tested, but there's some early results that indicate that involvement in these sort of online computer brain training exercises could be helpful to cognitive health, but there's no conclusive evidence yet. The studies have been relatively small, and right now people have had to be very intensely dedicated to doing the activities. So we're talking about 3 to 4 times a week, 30 to 40 minutes each time over the course of 8 to 12 weeks. And that's a long-term commitment if we expect people to maintain that forever. So I think we're still in the process of determining what combination of activities, at what intensity, and over how much time is really going to be key to helping people to combat HAND. But there's also lots of compensatory strategies, which are things like using a day timer, using an alarm on your phone to remember to take medication, those kind of things. So that's cognitive health. So again, we're going to not talk too much about disability, except to say that about a quarter of people who are aging with HIV report activities of daily living challenges. Activities of daily living are the things you have to do to get by every day. Feeding yourself, dressing yourself, bathing, etc. And 18 to 46.5% report challenges with instrumental activities of daily living. And these are sort of the other activities more broadly that you have to do to get by. So grocery shopping, cleaning your apartment, those kind of things. That's a fair amount of challenge with things that are really vital to your independence and your well-being. Also, a quarter of people had had a fall in the last year. These are significant impairments because many people, it's very important to them to remain in their own homes, to remain as independent as possible, and these are the kinds of things that make that difficult. So factors that can increase the risk of disability in people living with HIV are aging, poorly controlled HIV, so high viral load, greater number of health conditions, so if you're living with 4 or 5 different health conditions, that can definitely increase the risk. And also people with a low CD4 nadir, which means that that's the lowest that your CD4 count has ever gone. So people who were diagnosed before HIV treatment may have had a low nadir. Yeah, well, so I can definitely direct you to where you can find the data. But what's important to remember, though, is in that survey, that's not saying that HIV is the direct cause of those symptoms. It's saying that that people living with HIV are prone to experiencing those symptoms. It may be HIV, but it may be other factors as well. But it would still be important to share those study findings with your doctor if you want to help legitimize some of what you're experiencing. But sometimes this is actually, unfortunately, how ageism gets manifested in healthcare, is that a lot of things that are experienced by people who are aging are just attributed to normal aging. And the reality is that deteriorating health is not normal aging. That's that's problematic for you if you're experiencing muscle pain and joint pain. So, you know, passing it off as just normal isn't really that helpful to you. So even if it's because of aging, it doesn't mean it still shouldn't be taken into account. So strategies, some strategies that people living with HIV might find helpful in terms of coping with disability are self-management and daily living strategies like exercise, diet, sleep, hygiene, and energy conservation is something that I've heard really often from people living with HIV, that as they age, they've come to recognize that they just can't do the same amount of things in a day as maybe they once could. And recognizing that and scheduling their life according to knowing that has been really helpful for them. So instead of making back-to-back-to-back doctor's appointments, groups, social outings, etc., limiting those things to a few or one per day, and then having some energy left over to do the things they actually want to do, not just all those things they have to do. Rehabilitation services like physiotherapy can be really helpful. And for those of you who don't know, the day health program that started up at Casey House is going to have a physiotherapist on staff. And so if you're having mobility challenges or pain, seeing that person would probably be a real asset. Also, in terms of strategies for coping with disability, having the support of the people around you. So if you're having challenges doing things like grocery shopping and cleaning your apartment, it's really helpful to have people around you who can help with those things. But also there are services and supports available, like home care. There are some household maintenance services available through, for example, Wood Green, which shares this building. They come in and they have volunteer snow shovelers, for example. So if you live in your own home and it's getting hard for you to clear that snow, you can get on the list for that kind of service. Having your meals delivered, and then of course also making sure that there's no underlying medical cause to some of what you're experiencing. And we at Realize help to organize rehabilitation practicum placements for students in HIV organizations. So sometimes you might come across an occupational therapist or a physiotherapist actually working in your community HIV organization. So that's why I mentioned the program at Casey House, because you don't need insurance to access that. So if you live here in Toronto, which I assume most of you do, that's one resource that would be available to you without cost. But you're absolutely right, rehabilitation services were delisted from OHIP many years ago, and unfortunately don't look like they're being added back anytime soon, even though they're really vital to people's independence and ability to overcome some of these disability-related challenges. And so mental health was one of our key topics here. So I'm sure many of you have heard about syndemic theory. Have you heard about this word?
Yeah.
So basically what syndemic means is syn means at the same time, things happening at the same time, and epidemic is the second part of the word, which means something that's causing a problem across a population. So syndemic, if you smush those words together, it means many different problems happening in a population at the same time. And the reason why we use this word syndemic when we talk about mental health and HIV is because what we see many factors coming together that make people vulnerable to HIV infection and then continue to affect their mental health and quality of life as they live with HIV. These things are things like substance use and addictions, mental health challenges, histories of trauma and abuse, bullying and stigma, comorbidities and other health issues. And so the point of this, and the reason why there's a glass of water here, is all this to say that if you ask someone to hold this cup of tea for 5 minutes, they're probably going to say, sure, it's fine, I can hold this for 5 minutes. Okay, what if I ask you to hold this cup of tea and this phone and this pile of papers for 5 minutes? Well, it's getting heavier, so it's starting to cause a little more weight on my arm. What if I say, you also have to hold this and this, and now you don't have to hold it for 5 minutes, you have to hold it for 5 hours. Then my arm is probably gonna start getting a cramp. What if I say you don't have to hold it for 5 hours, you have to hold it for 5 years?
5 years?
And you can't put it down. Your arm is basically gonna seize up, and it's gonna be really hard for you to do all the other things that you need to do in your life, holding all of this stuff. If you picture that each one of these objects is one of those things I just mentioned, having an addiction or a mental health issue, experiencing trauma, stigma, abuse, all of these things, the more you put on someone or the more you put onto a community and weigh them down, the more mental health challenges that can arise. And this is why we talk about syndemics being such a key concern in the world of HIV, is because for many people living with HIV, they are coping and dealing with many of these things at the same time. That's really challenging. So when we think about mental health, HIV, and aging, often we hear the word resilience. And so resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. So what we see is that despite having to hold on to all those things, many people living and aging with HIV have actually gotten really good at getting through their lives, right? And that's awesome. They've developed strategies and tools and supports and coping methods of coping to really get through all of these things that they're experiencing. And actually, as people age, they're much more likely to describe themselves as aging well, even though they're dealing with more health conditions than when they were younger. So resilience is something that tends to develop with age. And it's because of what you were talking about earlier, is that through more life experience, through overcoming more types of adversity, people often become better at finding ways to cope with those things. And so for many people aging with HIV, they have developed a large toolbox of things to help them get through, which is not to say that they're not still experiencing some of those same challenges. It's just that they have developed some of the tips and tricks that they need to get by day to day. And so older people living with HIV appear in the research to be extremely resilient. Many people remain quite optimistic and in control of their lives, and that's really good news. Actually, what we see is that mental health tends to improve in HIV the older you are. So younger people living with HIV actually experience more mental health challenges than older people. Some of the things that contribute to mental health challenges in older adults living with HIV can include living with HIV and all the things that come with that, but also living with other comorbidities and concurrent health conditions, stigma, and finances. One of the things that the research shows is that those money issues that we're going to get to talking about in a little bit can be very stressful and affect people's mental health. Just let me get through this point. Significant risk factors for depression in older community-dwelling adults, not people living with HIV, just older people in general, include bereavement. So that's an issue that many people living with HIV have experienced, the loss of someone that they care about. Sleep disturbances, sometimes due to HIV medications, as some of you might know. Disability, again, occurs in HIV. Prior depression, and being female. So if you combine those risk factors in people living with HIV and the risk factors in people who are older, it sort of creates a perfect storm amongst people who are aging with HIV, that there would be a lot of contributing factors to mental health challenges. The problem with mental health and aging is that oftentimes those symptoms go unnoticed. So people go to their doctors, they report that they're tired, they've sort of lost motivation or energy to do some of the things they liked to do before, they're having aches and pains, difficulty concentrating, and their doctors say, to repeat back what was said earlier, yeah, that's just sort of what happens when you get older. That's not true. You don't have to lose your love of life and your enjoyment in everyday activities because you're getting older. Those things can be signs of depression that can actually be overcome. And so it's really important for healthcare providers to put on a different hat when they're dealing with people who are aging, not just to say, yeah, those things are aging, but maybe there are actually some strategies that we need to put in place. So just from a specific study of stress among adult immigrants living with HIV in Toronto, some of the things that that study found was that there was a link between depression and the distress that was caused by HIV symptoms. And so feeling in control or developing skills to help cope with those symptoms actually greatly helped people overcome their depression and distress, which is really important. I guess I was going to say here that, oh yeah, the study also found that length of time living in Canada and ethnic minority status was not as strongly associated with depressive symptoms, which was surprising to me. But then I sort of read a little bit further into the study and found that only people who spoke English or French were included in the study, and people who were included in the study were already linked to care. So those are people who haven't had access barriers that other new immigrants might have that would actually make it difficult for them to get services. So that might be why some of those things haven't come into play in that study. What is important about the impact of depression is that it can contribute to those neurocognitive symptoms, memory, concentration, etc. It's an independent predictor of heart failure in people living with HIV. So unmanaged depression can actually damage your physical health, which is really important. Obviously, lower quality of life if you're feeling depressed and down, and less adherence to medication. These are all critical in terms of maintaining your physical and mental health. And then here are some of the interventions that are coming out in the research that are available to help improve mental health amongst people aging with HIV. So the research shows on the whole that fostering a sense of mastery and individual control where someone feels like they can take charge of the things that are happening in their life is key. Setting their own goals, problem-solving skills being built, and helping people work through past negative experiences like victimization are all really important. And I think this is key to your point about JIPA and NEPA. Giving people a sense of control over their lives and the lives of the people in the community is really key to helping people feel stronger and more mentally stable. Also building resilience, so helping people develop the tools they need to think about negative situations and reframe them into learning opportunities and things that they can move forward from. Social support also being a key component. Now, one of the studies that I came across is that a multi-day mind and body intervention based on Native American philosophy has had some preliminary positive effects on mental health in people aging with HIV. Similarly, there have been teletherapy groups that have been helpful. So groups that are managed by a trained counselor, where people aging with HIV are calling in and having like a group session over the phone, have started to show some positive results, but the research is really limited. So still, we're in the midst of trying to figure out what are the best strategies for helping people who are aging with HIV and experiencing mental health issues move forward. Social support, I won't talk too much about this because we are getting a little tight on time, but just wanted to mention some sources of social support that are really key to people who are aging with HIV, family, but also families of choice and friend networks that people have established over time, peer networks, and groups like this one, but also spiritual communities. So we did talk a little bit earlier about spirituality, and there have been some recent studies that have come out that actually showing that spirituality is a key component for many people aging with HIV in terms of their support and having people around them. And I can share those references with you if you like. There's been some research also to show that people aging with HIV are often doing what's called social pruning. Social pruning essentially is exactly like pruning your garden. It's cutting away the negative things. So people describe that often as they're getting older with HIV, they're actually dissociating themselves from people in their lives who they find are negative influences or who are weighing them down or taking more than they're giving. And this is really important because it shows that choosing to surround themselves with people who lift them up, who support them, who they can offer mutual support to, and who make them feel good. And there's something to be said for actually having a smaller quality social network than a larger stressful one. And so that's shown here in the research. Activism and volunteerism, really important components, and something called generativity. So as people get older, there is a real social and psychological benefit to contributing to the generations who come after you. So many programs are now being geared towards mentorship and pairing older people living with HIV with younger people living with HIV or those who are more newly diagnosed, because there really is a lot of information and skills and strategies that can be passed down. And that's beneficial not only to that younger person who's getting the information, but the process of giving that is beneficial to the other person as well. We talked a little bit about ageism. I'm not going to talk too much about that. HIV stigma, also a huge barrier in terms of social inclusion. But also just important to mention that HIV stigma and ageism also intersect with all of the other isms. So discrimination based on gender, based on sexual identity, based on status in Canada, race, ethnicity, all of these things are really important. And the more of them you add to the mix, the more someone can feel excluded from society, from friend networks, etc. And these are challenges that need to be overcome. One thing that I thought was interesting was I found a study on the importance of friendship in older adults. So this was a study of Japanese older adults, 4,000 of them, which is quite a lot. And they looked at people who were socially frail. So people who were going out less frequently, not visiting friends as much, feeling unhelpful, living alone, or not talking with someone every day. So in other words, being isolated. And they found that being socially frail was associated with both cognitive impairment and physical health issues. So being isolated and alone was impacting people's health. But what they found was that social activities with friends was important, even more so than with family at an older age. Having friends around you, people to do fun things with, people who care about you, is actually really important to increasing positive feelings, decreasing negative feelings, and improving life satisfaction. So find at least one good friend and latch onto them. Okay, finances. This is another one of our key topics.
6:59.
So, yeah, winning the lottery would be key. But unfortunately, not many of us are probably going to. So, Ontario research study found that disability was one of the main reasons why people aging with HIV were retired, unemployed, or otherwise disengaged from the labor force. So this is another reason why disability kind of comes back through some of the other areas, is that it can really interfere with people's financial stability. And 40% of the research participants who were older were earning less than $20,000 per year. And that's really tough to live on. And I'm sure many of you can share experiences with that, but also strategies that you used to help cope with having a limited income. One thing, or a few things I want to mention that are specific to aging, is that sometimes when someone hasn't been working for a long time, or when they haven't lived in Canada for a long time, they may not be eligible for some of the pension earnings that someone might otherwise be eligible for. So Being eligible for the Canadian pension plan depends on the amount of years you worked in Canada and the amount of years you've contributed to CPP. So being disengaged from the workforce and or having periods when you're not here or not spending your whole adult life here can really affect how much CPP you're eligible to get when you reach retirement age. Really, so it's your CPP is a percentage of your eligible earnings up to a certain amount. So people who are Canadian citizens are eligible for old age security. That is regardless of whether you've been paying into CPP or not. Those with where that is their only income at retirement are also usually qualify for GIS, which is the Guaranteed Income Supplement that boosts up their income. And then CPP is another benefit that's given to people who've been paying into it over their lifetime of working here in Canada. So if you receive all three, well, you probably wouldn't receive all three. If you receive OAS and CPP, you're receiving the maximum CPP, your income will probably be pretty good per month. But if you're receiving only OAS because you're not eligible for CPP because you haven't worked, it's going to be a lot lower in amount. And I'm going to talk about some of the challenges of that. So let me come back to you because I think you're going to see a little bit how this plays out. The other thing that you may be eligible for if you've been working over the course of your adult life is a private pension. This is becoming more and more rare. But a lot of people who are reaching older age now would have been paying into a private pension as well. So they would be collecting OAS, CPP, and a private pension if they had been able to maintain work for their whole adult lives. I don't want to quote the amount, but I believe that if you have OAS and GIS, so the standard pensionable income and the top up for people who are not receiving any other sources, I think it's equivalent to what people get on ODSP. And then if you receive CPP and you receive the maximum, sometimes it can be around $2,000 a month. But as I'm saying, for many people, especially people living long-term with HIV, disengagement from the workforce over the life course has meant that they haven't paid into CPP over time. And that can be problematic when they reach retirement because they don't have that extra income coming in, and they don't necessarily have a private pension plan either, right? The other thing that's important to realize is your expenses change when you get to the eligibility age for retirement. So you may have more pay out-of-pocket medical costs that aren't covered by OHIP or by any private benefits that you have. You also have increased housing costs, especially if you are on rent geared to income. So just to put this in perspective, if you're claiming ODSP and you're in a rent geared to income housing, there's a set amount of your benefits that go towards that housing, right? And it's a dollar amount, it's not a percentage, it's an actual set dollar amount. Once you start claiming your pensionable or your pension income, that rent geared to income becomes 30% of your income goes to your housing. And I will tell you that 30% of that income is much higher than the set rate that you're paying on ODSP. So even though you may be eligible for more pension income, you'll be paying more for the same housing. So you may not be bringing in more, you may in fact be left with less. This is all not to be scary, this is just to recognize that when you reach this age of eligibility for these pension benefits, and before then even, it's really important to explore what's going to change about your income and your expenses. and to talk to someone about this. So I mean, Andrew's saying he's helped out clients who have made this transition before. I'm sure that he would be someone you could speak to. But also the folks at PWA who do the benefits and assistance case management. I know Rajesh specifically has a lot of experience supporting people in this transition. Become eligible for your old age security as soon as you reach the eligible age. And I don't think ODSP finishes until that age.
Okay.
So I'll double check.
Okay.
I hear you, I'll double check, but I don't think so. With CPP though, you do have to apply for it to start, and there is a waiting period. So you may be getting your OAS, but not your CPP. Strategies that I think are important around finances. In order to get your proper benefits, you need to be up to date on doing your tax returns. So looking for a volunteer tax clinic like the one at ACT is really important, because as a senior, you become eligible for a variety of additional benefits that you may qualify for, but you have to have submitted your taxes. We've spoken about OAS and GIS a little bit. In Ontario, if you rely on OAS and GIS and you have no other pension income, you may also qualify for something called GAINS, which is a provincial top-up to boost your income just a little bit. There's also something that I thought would be useful for you to know is that Canada has social security agreements with a variety of other countries, where if you've lived in Canada for part of your working life and in those other countries for part of your working life, and in both places you contributed to their equivalent of CPP, with many countries there is an arrangement where CPP will credit you those years. So for example, India, Japan, China, Philippines, and Korea all have these agreements with Canada. So if you have worked in one of those countries and contributed towards a country pension, there may be a way that that time that you worked would be added to your eligible time for CPP. Other things to be aware of are the Ontario Drug Benefit Program. So when you reach 65, you do become eligible for having your medications paid for by the government. And this would be different if you're not already on ODSP. It's similar to having a drug card through ODSP. And you pay only a very small co-payment. For people who need dental work, who can't afford it or don't have coverage, there are student clinics, for example, through U of T that offer income sliding scale based on income and lower fee dental work. So important to think about that, especially as you get older and may need dentures, as we heard before. Horrible, horrible dentures. Also, something that's come to my attention relatively recently is OW and ODSP have a special benefit called the Mandatory Special Necessities Benefit. This is really key to people, for example, who are experiencing incontinence and who have to pay for adult diapers or absorbent pads. And you know, this is a really serious issue for people in terms of isolation. If you can't afford those supplies that make you comfortable and confident to go out and socialize, knowing that you're not going to have an accident as an older person out in the world, then you're going to be fairly isolated. And so if you rely on OW or ODSP, you can apply for a special benefit that helps to cover the cost of those supplies, of diabetes materials, and also any surgical or wound supplies that you might need. And then there's the Assistive Devices Program, which helps you purchase mobility aids, such as walkers, canes, crutches, wheelchairs, those kind of things. If you don't know about this already, ACT has a program called the Community Financial and Estate Planning Management Program. This is a program with 5 sessions that runs. The sessions are on things like drug coverage, private insurance and life insurance, financial planning for people coming up to retirement age, funeral planning, and estate planning. This is coming up in the fall, beginning on September 6th. And you can register for these sessions independently, or you can go to all of them. but I encourage you to check those out if you have more financial questions that you want to have answered. Another really good resource is this resource from Open Policy that's called the Low Income Retirement Planning Toolkit. It's really instructive in terms of helping you to make decisions about when you should claim your CPP, for example, to maximize the amount that you'll be eligible for, because you don't have to get it right when you're 60. You can actually delay it, and there are reasons why you may choose to do that, and those are all outlined in the retirement on a low income toolkit. Housing, another one of our big issues. So basically what we do know is that there are a lot of gaps in terms of housing related to HIV and aging. And so there's long waits for subsidized housing for people of all ages. There are sometimes needs for different types of housing environments. If you're older, for example, you may need an accessible apartment. If you're relying on a mobility device, you may need some support around you if you're experiencing cognitive impairment, etc. And a lot of people have anxiety about where they're going to live or what supports they're going to get in their living environment as they age with HIV. So some strategies that are happening at the policy level, which is often where housing decisions occur, is that there is, a constant advocacy movement for more affordable housing and for increasing the income support levels that people receive. But also, there's a move, I think now, to incentivize builders to build larger units, which can house multi-generational households. So recognizing that this is the way that people live in many different settings around the world, that their children or grandchildren help to take care of them as they age, instead of building just one-bedroom apartments all the time everywhere, starting to build 2- and 3-bedroom apartments so that families can live together and can help support that aging process for each other. In terms of accessibility, a lot needs to be done in terms of making existing housing more accessible to people who experience disability. So putting in ramps, putting in shower aids, etc. All of this needs to be done and is starting to happen. For example, in the condo that I used to live in up at Yonge and Eglinton, the whole building was newish and it was built to be accessible. So all of the light switches were lower, none of the entryways or the doorways had any kind of a barrier, and the whole building was like that. And it's starting to become more profitable even for companies to build what they call visitable housing. And visitable housing basically means housing with no barriers that anyone can get into and out of, whether they're visiting or living there. Sometimes what people need in terms of making their living space more accessible is actually an assessment with an occupational therapist. And if you're having a lot of barriers in terms of your mobility or your stability, you can contact your home care organization and arrange to have an occupational therapy assessment that can help you determine whether you need grab bars for your shower, that can look for possible tripping hazards like rugs that are loose and you could fall. And these are really critical considering we saw earlier that about 1/4 of people living with HIV who are aging had fallen in the past year. Even just being aware of the barriers around your home that could lead to you being hurt are really critical. And then of course, there are some benefits available for home and vehicle modification for those of you who own a home or need to make your vehicle more accessible. Things that are specific to HIV, some work that we're doing at Realize specifically is to look at how we make existing seniors' living environments more accessible to people aging with HIV. So one of the things that we're doing is a project called Working Together. We go to long-term care facilities, home care agencies, senior services and HIV services, and we educate everybody together on HIV and aging. And we make sure that those housing environments are going to be non-judgmental for people living with HIV, that their policies are reflective of the needs of people coming in, possibly at younger ages or with different needs than their typical clients. And we talk to them about some of the stigmas that people may encounter when they access aging-related services as people living with HIV. And we've trained over 100 people so far in the pilot, and now we're offering this course to service providers online across Canada. Casey House also offers training through their video series, Compassionate Care in a Changing Landscape, similarly to prepare long-term care homes to be ready to accept people aging with HIV into those environments. And we have someone in the room who's an expert on that, who I can refer you to if you want to speak more about that. So I'm getting the time signal. What have we not talked about that was on the list? Comorbidities. I will do this in 5 minutes or less. We're not going to talk about sex. We're going to talk specifically about this. So, very important as someone ages with HIV to address some of these chronic or age-related health conditions that can sometimes be more prevalent in people living with HIV. Things like cardiovascular disease, heart attack, stroke, etc. Other cardiovascular risk factors like high blood pressure and lipodystrophy, so fat redistribution in the body that sometimes results from HIV medications. Managing pulmonary disease, which can be more prevalent in people living with HIV, so that's chronic obstructive pulmonary disease, asthma, things like that. Diabetes, various forms of cancer, and also bone disease, and specifically some HIV drugs can really affect bone mineral density, increasing the risk of bone disease in people aging with HIV. So it's really important in dealing with these things. I'm not a doctor, I'm not going to tell you what to do to cope with and treat all of these illnesses, but it's really important you have a doctor, and especially that you have a general practitioner. So many people have an HIV specialist. That person is great for treating your HIV, but I would argue that that person isn't the best person in terms of dealing with your aging-related concerns and all of the things that you should be doing in terms of screening for aging-related illness. So routine health maintenance, screening for things like colorectal cancer and breast cancer, diabetes, having your regular immunizations, getting support around treatment adherence, especially if you're experiencing cognitive impairment, having a functional assessment. So if you are experiencing balance issues, mobility issues, making sure you mention that to your doctor so that you can get referrals to things like physiotherapy. Behavior change interventions, nobody likes these, nobody wants to do them. Exercise, quitting smoking, getting better sleep habits, all of those things. And finally, palliative care. And I don't mean palliative end of life, although that is important as well. Palliative approaches to care is basically about symptom management. So recognizing that it's not all about having diabetes and treating diabetes, having HIV and treating HIV. It's about recognizing those nondescript symptoms like muscle pain and joint pain, where we don't know exactly what the cause is, but that doesn't mean we can't do something to manage it. So making sure you're working with your healthcare provider and telling them about those changes in your symptoms so that they can help you to manage those. That's it. That's all.